All right, folks. Good morning. It's a pleasure to be here. I love these events. I think it's always fun to have this conversation with you guys and get outside of the clinic, make it more easygoing and friendly environment that in our office space with our white coats and whatnot. I'm Ariel Grajales. I'm one of the myeloma doctors at Moffitt Cancer Center. A little bit about myself. I'm originally from Colombia, but I've lived a little bit everywhere, France, Puerto Rico, now Florida. And I'm very passionate about myeloma, actually. It's a disease that I have a love and hate relationship with, right? Obviously, we all know that myeloma has this unfortunate label of incurable, right, which sucks. But also, I always like to see the disease as not representative, right? Because incurable is not untreatable. And that's the main point that I want you to take from today. And in reality, in the past 20 years, we've made such great changes to the disease that the landscape, as you saw earlier with Jenny's slide, that the landscape has completely, dramatically changed, right? So we're not talking about the same disease anymore for sure. These are my disclosures. And when we talk about myeloma, the first thing to remember is that we're dealing with what we call a plasma cell dyscrasia. By the way, I love seeing patients of mine here. These plasma cell dyscrasias basically are diseases that come from an abnormality in plasma cells. And those plasma cells, which are the ones that are the type of white blood cell that produce antibodies, right? They constitute our immune system. They should be producing what we call a polyclonal expression of protein. But at some point, we acquire mutations to no fault of your own, essentially. We don't truly understand what the main cause of myeloma is other than age. There's also an ethnicity associated with it. Environmental is a little bit more debatable and questionable. The more straightforward association has been with Agent Orange in Vietnam. So for those vets, we typically have seen an increase in that risk. Also a hereditary component. It's not very well understood, and I have a slide on that regard. But what I want to say is that everybody, as you can see here in this graph, nobody starts with myeloma right off the bat. You guys all started with your journey with a precursor state. And a precursor state is not a cancer itself, right? You have MGUS and smoldering myeloma, and I'll explain that in a minute. But that happens over years and decades, right? At some point, that burden of disease gets big enough to cause issues, and that's when we start needing treatment, right? This is right here. And the reason why it's incurable is because at some point, the disease is gonna relapse after the first treatment, and then second, and then third, and then fourth, and so forth. So it's, I always make the analogy of myeloma as a marathon and not a sprint race, okay? And the difference between these plasma cell dyscrasias is very simple, right? Numeric for the most part. Let's make a wall in between these two guys on the left and myeloma. These folks right here with MGUS or smoldering myeloma, these are the ones that I'm referring to as a precursor state, right? Monoclonal gammopathy of undetermined significance. I would have been a terrible surgeon. Do you see how I shake? Those patients have less than 3 grams of protein and less than 10% plasma cells in the marrow. Smoldering, on the other hand, they have 3 grams of protein or more and 10 to 60% plasma cells in the marrow. But they lack something very important, symptoms. Because patients with myeloma have to have these symptoms right here, CRAB. This acronym summarizes high calcium, renal injury, anemia, and bone disease. Having one of those with the presence of monoclonal protein, that's diagnostic of myeloma. But actually, there are some patients that do not have a CRAB feature and still have myeloma. And these are these guys right here with a myeloma defining event. And this is a concept that came up several years ago because it was essentially a subgroup of patients that had a really high chance of ending with end organ damage in the near future, right? More than 60% plasma cells in the marrow, light chain ratio more than 100, or more than 1 lesion in an MRI, okay? And come on. When I said that precursor state are not a cancer, I meant it in reality. And we have to compare apples with apples and oranges with oranges. Precursor states it's actually a very common scenario. We estimate that nowadays there's about 12 million people with precursor states in our country. It's not a negligible number altogether, right? But when you compare that to the 35,000 new cases of myeloma per year, you see the discrepancy. You see how the rate of transformation from a precursor state to an active cancer is not that high. But it does happen. So if you grab the whole population in the United States above the age of 50, about 10 to 15% of the patients of that population will have either MGUS or smoldering without knowing, right? Because there's no screening test for this. And here you can see the progression from one another, right? MGUS, very low, 3% per year for the first 5 years. After 20 years, about 21% of the patients will end up having myeloma. But smoldering is higher, right? 10% per year for the first 5 years, then 5% for the subsequent 5, and then 3% thereafter. Still, this number is not 100 after 20 years, but it happens. What we have to remember is that not all myelomas are the same. Not all smoldering myelomas are the same. And that's why we came up with these different methods of stratification, right? The most commonly used is the 2-20-20 risk stratification based on the 2018 Mayo program, right? And this incorporated 3 factors: size of the monoclonal protein, light chain ratio, and the marrow involvement. Having no risk factors, 0, actually gives you a 2-year risk of progression of 6.2%, I'm sorry. If you divide by 2, that's 3. That's very similar to what I told you about MGUS, right? So those patients in green will have a more indolent course of the disease. On the other spectrum, 2 or 3 risk factors, these guys have a 44% chance of turning into having myeloma in 2 years. So that's clearly more than what I told you earlier, right? So these folks are typically the ones that we want to enroll in a clinical trial, and we're going to talk about that in a minute. Obviously now with the incorporation of the biology of the disease, we can look at the results a little deeper, and in a more granular way, we can observe and try to predict how patients will do based on their numbers, okay? These are the folks that we want to try to capture on clinical trials for sure, okay? Now, early detection matters, right, for most cancers. And we know that for breast cancer, lung cancer, colon cancer, all these solid tumors. But myeloma is a blood cancer, right? So there's no such a thing as a metastatic myeloma. That's kind of a crazy misnomer because you have blood everywhere, right? You have marrow everywhere. So no, that does not exist. But these precursor states, we don't have screening tests for those. We simply don't. And different, like I said, to breast cancer, for instance, when we tell you, no, we watch and wait, you guys look at us and say, dude, you're telling me that I will have a cancer potentially and you're not going to do anything? Well, that's why we always should encourage you guys to participate in clinical trials, right? Because as Jenny said, 20 years ago, this landscape was not the same. And it's not because we're just handsome and good looking like me. It's just because after years of trials and investigation, we have great options to offer to you guys. And hopefully we get to that cure that she was referring earlier, because we desperately need it for sure. That concept of functional cure does exist, right? Because ultimately, at some point, we're all gonna meet our maker. And our job is to keep you guys alive and well long enough so that 275 does the job, right? But we shouldn't be content with that, right? We should have a better conversation altogether. So actually we have and I wanna bring this up, the PROMISE study is a multi-institutional trial that we have for relatives of patients with myeloma, right? First-degree relatives of patients with MGUS, smoldering, or myeloma, or any African-American, right? Because remember I told you, minorities are more affected by this. Blacks and Hispanics, we have a higher risk of developing myeloma. And so this is for first-degree relatives, age 30 or older, and self-enroll. You just go to this site right here of the PROMISE study stuff to get, I think they have a better thing here. Just sign up for this. You get sent a testing kit, get tested, and if it comes back positive, you're plugged into one of our clinics. Okay, so that's actually very important because we want to make sure that we capture those precursor states and we understand whether or not there are clones that we could have done something about before. Okay, always think about trials. I think that's the main message. But then at some point, it's going to hit the fan, right? And that conversation in which, well, you cross that threshold either by numbers, by imaging study, whatever the case might be, and now we're dealing with newly diagnosed myeloma. Now what, right? No longer watch and wait. Now we have to intervene because we have to prevent this end organ damage to getting worse. Typically, the first question to ask ourselves is the patient transplant eligible or not? And transplant is an elective procedure, right? It's not because it's a cosmetic procedure, of course, but it's an elective procedure because it doesn't change the overall survival. It improves the progression-free survival, especially in those patients with high-risk disease, but it doesn't change how long the patient is going to live. And we've been doing transplants since 1983. I always make joke of Dr. Castañeda and Dr. Hansen because ultimately, although I was also trained in transplant, but melphalan is just a dumb drug. It's a nuclear bomb, right? We just wipe the marrow, bad guys go, but so do the collateral damage is the good guys. And that's why we have to give you these stem cells to keep you with a pulse, because otherwise without cells, you're not with us. And it's probably been one of the therapies that had the bigger impact in myeloma. I mean, think about it. From 42 years we've been doing transplant, there's been innumerable trials trying to debunk the role of transplantation. None have succeeded. Undefeated. This is the Mike Tyson of myeloma, for sure, right? But then when we have this patient transplant candidate or not, well, if we don't do transplantation, then we have to think about just induction followed by an ongoing maintenance. And we have to ask ourselves, what type of biology does the patient have? High risk or standard risk? And I'm sure your physicians have already, or at least I hope that they have tried to explain what the mutations are. Well, there is a clone, right? What is that driver? 3 bad guys, del17p, 14, translocation 414, which is a piece of chromosome 4 and 14 swapping places, and translocation 1416. Having one of those mutations doesn't mean that it's the end of the world, right? It just means that we have a higher risk of an earlier relapse. That's all what it means, right? And we have to look at that. And for us, it's important to know because it's gonna tell us what can we expect, and most importantly, how can we plan for maintenance? Because patients with high-risk disease, we tend to do 2 drugs as maintenance rather than just 1. This is what I was telling you about, these high-risk mutations, 414, 1416, and 17p deletion. This one is also a high-risk disease, 1q amplification, but it does not upstage you, okay? But you can see here that the patients on the red curve with no high-risk cytogenetics do better than those on the green one that have 1, 2, or even 3. Patients with what we call a triple hit disease tend to have a shorter response rate. Translocation level 14 is actually a very standard risk disease. It's not high risk at all, but it does open the door for an off-label use of another drug called venetoclax, okay? It's not FDA approved, but we can use it in the relapse setting and with great results. And we expect this drug to be approved for the myeloma in the near future. Now let's get to what can we do, right, for myeloma. And let's start with the transplant ineligible population, all right? So let's assume that the patient that we have in front of us is not a transplant candidate, age, comorbidities, patient choice, whatever the case might be. And historically, we extrapolated the data from SWOG 777 trial, which was the pivotal trial that came with RVD, right? RVD, it's been around since forever. And it was the standard of care for patients in the transplant eligible and ineligible patients setting because it was not intended for patients to be transplanted. Almost half of the patients ended up having a transplant, but that's why it applies to both scenarios. But MAIA was an amazing clinical trial that dramatically changed what we do for this population because it incorporated this guy right here, daratumumab, which was approved in 2015. And it's one of the drugs that have done a tremendous push in the treatment of myeloma. And in this trial, was a combination of Dara, Revlimid, and dexamethasone versus Revlimid and dexamethasone. Let's make this very heavy slide very simple. Progression-free survival, in other words, your remission. And we use the word remission with a lot of caution because that remission has a connotation of cure and whatnot, but if you want to call the remission progression-free survival, be my guest. But you can see how it simply doubled it. Overall survival benefit, absolutely, 64 months versus 90 months. So you can see how these three drugs made more sense. And this is one of the first trials also to explore this concept right here that one of my colleagues is gonna talk about, MRD negativity, right? Because MRD negativity should now be our goal. We should aim for that because it's a surrogate marker for progression-free survival or remission and overall survival. In other words, DRD, 3 drugs, much better than just 2 drugs. Now, most recently, we have 4 drugs, right? Because for transplant-eligible patients, we've done 4 drugs for some time. But now IMROS, which is a combination of isatuximab plus VRD, this trial explored this other anti-CD38 monoclonal antibody and compared head-to-head, essentially, randomized 4 drugs versus 3 drugs. ISA VRD versus VRD. Very complex schedule that I'm not gonna get into it because otherwise we're gonna spend a half a morning here. But look at these results. At the 60-month follow-up, so after almost 5 years, 63% of the patients were still in a remission. So that's why numbers like the SEER data that were mentioned earlier, these numbers are dated. And I don't want you, because the first thing that you guys do when you get diagnosed with myeloma is ask Dr. Google. And Dr. Google is very dark. He is very pessimistic. Don't listen to Dr. Google. That's why I love working with these platforms, because this is where you can get a proper information about your disease, all right? But look at the type of responses that you get. Clearly better with 4 drugs. And it's not because you're transplant ineligible that you should not be getting 4 drugs. People can get 4 drugs as long as they're dosed properly and with the right schedule, right? Because ultimately our job is to help you, not hurt you. And side effects can hurt you. So we have to know what we're doing, all right? And look at the MRD negativity, minimal residual disease, so the depth of response clearly better in this study as well. Benefit is another study with the same backbone, but essentially kind of a different schedule altogether. And look at this. Very similar responses. Look at these curves. They're almost horizontal. This is not the dramatic, horrendous curve that we used to have in the past, right? So this is exactly what I'm telling you about. Don't listen to Dr. Google, all right? Cepheus is another study that has been recently presented in our myeloma meeting in Brazil last year and in ASH as well. Another combination of 4 drugs, but this time instead of isatuximab, daratumumab. 4 drugs are better. Look at this. 54 months PFS, almost 70% of the patients were still in a remission. Look at the MRD negativity, which is actually nowadays a primary endpoint for most trials, thanks to the work that Dr. Langren has done 2 years ago or a year ago. ODAC accepted MRD negativity as a primary endpoint for trials. Because in myeloma, we have a really good problem to have, and is that you guys are living too long. To get to that endpoint, it takes decades. By the time that we get to that endpoint, the drug is obsolete. So MRD negativity helps us get there faster, essentially, okay? Guys, remember what I told you about transplant, elective. Look at the progression for survival in both trials. You can see that the curves are different. With transplant patients have a longer remission. And these are 2 different trials, the termination trial and IFM 2009 and the termination trial. They started as being the same study, but in the US side, we didn't like the fixed duration maintenance of 12 months. And so we came up with this determination with a nonstop maintenance. 3 conclusions from this study. 1, PFS was better. The remission time, 47 versus 35 and 67 versus 46. Second conclusion, overall survival was identical in both scenarios. The graph is not there, but they overlapped. But the third one, indefinite maintenance, made more sense than fixed duration. 67 is clearly better than 47. although that's cross-trial comparison, but we can make that determination for sure. And I told you that it was especially important for patients with high-risk disease, right? Because you can see that the separation of the curves is broader for these guys when we talk about transplantation. Now that we have explained why transplant makes sense, let's move to those pivotal trials that have led to that. Griffin, DRVD. So remember what I told you about CFIUS? Very similar, 4 drugs. And just to put this out there, because I probably should have done that at the beginning, remember that the treatments in myeloma, the therapies are divided: proteasome inhibitors, we have 3, Velcade, or bortezomib, let's use the proper names, carfilzomib, and ixazomib. We have 2 anti-CD38 monoclonal antibodies, daratumumab and isatuximab. We have 2 IMiDs, lenalidomide and pomalidomide. Thalidomide is still around, but we never ever use it. I think in the past 5 years I've had maybe 3 patients on thalidomide. That's because they came with, but we rarely use it. We have anti-SLAMF7, ilotuzumab. We have panobinostat, which we rarely need nowadays. But we have newer drugs. We have bispecific antibodies on the 5th-line setting, teclistamab, elranatamab, and talquetamab. And we have 2 CAR T-cell products, right? Cilta-cel and ida-cel, right? So no longer the 3 crappy options that we used to have. But here in this trial, we're comparing 4 drugs to 3 drugs, followed by transplant, a short consolidation, and then maintenance to disease progression or intolerable side effects. Perseus, and I'm going to show you the graphs in a minute. Perseus, similar. Dara, VRD plus minus Dara, randomized. And look at the numbers. Look at how this progression-free survival at 48 months, so 4 years, 84% of the people were still in a remission. In both scenarios, we're talking about a 95% plus chance of response. And that's typically the first question that you guys ask. Okay, so what happens if I do nothing? It's not the right answer, because myeloma has a 100% chance of killing you. If I tell you, go to the casino and you have 95% chance of winning, you will go to the casino every Friday and you would not miss a day. This has 95% chance. Could you be in the 5%? Absolutely. Numbers are numbers, right? We don't have the crystal ball. But 95% is on your side is much better than 100% against you, right? So always think about that. And look at the depth of response, MRD negativity, absolutely beautiful graphs altogether, because depth of response matter. That's extremely important. More trials about quads, GMM-HD7 and concept, very similar concept, essentially, no pun intended. More drugs, better results. 4 drugs are better than 3. Look at this. Progression-free survival, better. MRD negativity, better. So what is the rule of thumb? More drugs, better results, essentially. Proper dosages. We should never be hurting you with the side effects, okay? MRD negativity was also better, of course, and for the sake of time, let's skip to this, but, and we're gonna talk about MRD negativity in a minute as well. Novel drugs also, isatuximab in combination with Kyprolis, Revlimid, and dexamethasone, that also has been explored. The Ischia trial was a plenary session, actually, ASH 2 years ago, and it showed phenomenal responses, especially for those patients with ultra-high-risk myeloma. Look at the MRD negativity, which was the primary endpoint for this study. The MRD negativity for very high-risk disease, 77% for the patients on the 4-drug arm versus just 27. So clearly not the same number. There's a delta of 50 right there. And I want to end this very boring talk about newly diagnosed myeloma with something very important. Trials, trials, trials. I told you already about PROMISE study. PROMISE study, great for relatives. We have trials in the newly diagnosed setting, right, at Moffitt. And I assume that most of you guys are local. We had Advance that we shared with University of Miami not too long ago. Hopefully a positive study. But nowadays, remember, for how long have we been trying to debunk transplant? 42 years, right? Now we have, and actually we have the primary investigator of the site PI here, Dr. Castañeda, for this clinical trial is the CARTITUDE-6. And this is a trial that hopefully is going to be a pivotal trial that will answer that question for us. What is the role of CAR-T in the newly diagnosed setting, right? So in this clinical trial, which is a phase 3 randomization 1-to-1, okay? DRVD, so 4 drugs, of course, as an induction, followed by either transplant or CAR-T with cell-to-cell. And then fixed duration maintenance. Always consider clinical trials, okay? For these, obviously, you have to be treatment naive, so untouched, but these are options. Whenever you have a relapse of your disease, always consider a clinical trial. And remember that in our world, when we think, because there is this misconception about clinical trials, I'm going to end up getting a tic-tac. No, we don't give tic-tacs to people because that would be criminal, right? If you have an active cancer, I would not be giving you that. It's either standard of care or something better, right? With preclinical data that has shown the efficacy. So always think about those studies because that's how we moved the needle in a better direction, all right? And I think to summarize this, remember, this should be individualized. There's not a one-size-fits-all when it comes to myeloma. Every single patient is different. Every single patient has a different biology. Every single patient has different comorbidities, and we have to tailor your treatment as such, okay? The depth of response matter. The times of a partial response, very good partial response, that is long gone. Now it's stringent complete response and MRD negativity that we should be aiming for. That's going to be the best predictor. It's better to be MRD negative and high-risk disease than MRD positive with standard risk disease. So depth of response matter. Backbones, I already told you, PI, IMiD, and CD38 plus a steroid, right, at the beginning. Then steroids, we have to shave it off. But the way of approaching, of tackling myeloma in different ways, it's extremely important because we want to try to avoid the escape mechanism as much as we can. Quads better than triplets, and clearly triplets are better than duplets. But there are some patients that even need a duplet, right, because they're just too frail. Right? If you have somebody who's 95, you're not going to do 4 drugs, right? You might consider just 2 drugs and take a response adaptive approach. And we've done that. We've actually presented some data last ASH about that. And it works, right? We can always tailor your treatment based on your needs. Transplantation. Every single patient should have a transplant consult. It's up to them to decide whether transplant makes sense or not. All right? Obviously, if you're 90, maybe that's not the right question to ask. But if you're around your 70s, you should have the transplant consult. You deserve that option. Hearing what's available doesn't mean that you commit to anything, okay? So always have that. Age, and like I said, we've done transplant on older folks, but renal function is not a contraindication either for transplantation. Even if the patient is on dialysis, transplant can be done, okay? So that's sometimes misunderstood in the community. And maintenance. Well, maintenance as of now, it's until disease progression or intolerable side effects. And we have the most studied drug in myeloma for maintenance is Revlimid, lenalidomide. Doesn't mean that it's the best drug. It just means that it's the best studied one. But now we have drugs that might make into the landscape, and we'll see what happens with that. And hopefully at some point we'll have also a fixed duration maintenance, right? Because myeloma has, I always say, 3 toxicities. Physical, with the symptoms of the disease. Emotional, because it sucks to have that incurable cancer. And financial, because these drugs are obscenely expensive, right? So we have to be very mindful of that. And the most important part, do not go off treatment because of lack of access. There's always resources available for you, either through foundations, pharma. There's always a way to help with that copay as well. All right, that's very, very important. I think that's it. 40 seconds.